as we've talked about, there are strengths of registries, there are strengths of RCTs, there are strengths of comparative effectiveness trials. One of the core and key pieces of knowing what are the quality determinants of the of a particular therapy, or in order to design a trial, is to know what level of disease might be sensitive to treatment and what contraindications there are, because one of the fastest ways to make a group of people better is to stop offering them care if you know they're not likely to benefit from it. And so a registry can certainly contribute to that knowledge by looking across all comers who have received a given trial of injection therapy, and to see who's more likely to benefit and who's very unlikely to benefit, and then just start not doing it on those people who don't benefit. The other piece of what we need to know, though, is what is it that determines a quality product in terms of the source of the bone marrow, because people can harvest bone marrow from the anterior crest, the posterior crest, from the proximal tibia. I've seen that done, and so the source of those cells and the method of processing and the composition of what's actually going into patients is important. So one can measure cells and one can define the process, but one of the questions that comes up is can we start to learn more about what we care about in terms of product by analyzing what's going into patients? Because if every time we do an injection therapy, we don't know how many cells are going in, of red cells, we don't know how many white cells, we don't know how many progenitors, but we also don't know how many platelets, we don't know how much of different growth factors may be present, we don't know what the exosome concentration is, that those variables that we're currently blinded to because we don't know necessarily what's coming off of the centrifuge every time we do one of these therapies is limiting our ability to try to make those therapies more consistent and more reliable. And so this where that I think we wanted to go with this target question is probably close into the next question on Scott on your side, which is, knowing we need to collect information about disease severity and patient and their outcomes, and knowing that we can collect information about the source of tissue and the processing method, how do we get better, or what opportunities do we have to take those group of committed individuals, and what opportunities do we have to build the network that says, okay, here's a group of people where we know exactly what they got. We know exactly how many cells, how many exosomes, how much growth factor, what kind of composition, because those are difficult things to measure, but it's possible to do that in a biorepository. So if we go to the next question.
And while we're there, Iain is a first author on an important paper, the JV Dish paper, the MIBO, the minimum information for studies in biologics and orthopedics, right? So that gets to this very question of a checklist for us, and that's 2017, if I recall, Iain, right? A checklist of what we should record for both cell therapy as well as PRP.
That's right, yeah, and a number of people on this call were contributors to that. That was a consensus statement. I think a big challenge that we look at now is that there's such a range of these biologics, and coming down to terminology as well, is that a lot of the products that are autologous blood products but wouldn't call themselves PRP may not feel that they are applicable to that one, and the sources, the methods, the composition variables might be different depending on what biologic they were. And I guess that comes down with the point you made earlier, Dr. Rodeo, about understanding what is the mechanism of action, because once we understand what the mechanism of action is, we can then determine the potency. And that's probably the important things we need to measure in terms of these data elements. So the more we understand about the underlying mechanism and biology, I think that will drive these important data elements.
So it goes back to we need basic research. We need funding for basic research so that can eventually inform our translational aspect in our clinical studies. So,
I mean, Scott, just to follow up on that point, because I think it's very important. We are, I would love to hear the opinion of the panel, especially George and you on this aspect. We still don't necessarily understand how primary OA, which is 80% of the OA that we see, what are all the physiopathology that is behind the disease, right? So we don't know which pathway is actually present in each of our patients, and there is a lack of a clear understanding of different subgroups of OA or subgroup of patients who would benefit or that we know how we are treating. So we're testing treatments that we don't necessarily understand entirely, or we haven't identified tests to measure potency or composition to treat a disease that we're still lacking a better understanding of what we're treating and what are the treatment targets that we're addressing. What are your thoughts in that area, especially focused in biologics?
I'm actually Scott Bruder. Scott, what do you think there? I mean,
I'm not sure I followed that question about the different. Forgive me, I lost the question, Nick.
So the thing is, I mean, we still don't understand the physiopathology behind OA entirely, and the treatment targets for OA are still undefined. And even more, we probably have different subgroups of OA, which we've not been able to categorize very well to date. Then on the other end, you have treatments that we still don't entirely understand, and they were kind of putting a mixed bag of things and delivering that to patients. So how do you conciliate the funding on both the treatment and the basic science of OA, moving the ball forward? Because I see that there are two moving targets, and we're trying to design studies to assess those two things that we still don't understand.
Yeah, I mean, that is a great question. I don't have a great answer, but I can tell you that from the sponsor side, from the industry side, you know, that they take a different view about who should be funding basic science studies. They're funding efforts at tens of millions or $100 million for trial cash is focused on demonstrating efficacy in a narrowly defined group of patients. And that narrow definition of patients is predicated on inclusion-exclusion criteria that are ultimately decided in conjunction with the FDA. I mean, you're completely right. The underlying pathophysiology is something that the Arthritis Foundation has funded for at least 40 years when I was a fellow. And so I don't have an answer to that.
I think so. I didn't mean to put you on the spot. I wanted to see your sense from the the kind of FDA sponsor side of things. I think clinically, Nicolas, it's a challenge. We need to continue to characterize our patients, all the relevant factors. And George had that nice slide earlier with all the different factors: age, comorbidities, sex, gender, number of other factors. And do the best we can to, again, phenotype our patients. And OA is probably a great example of what we call arthritis. Is is about 30 different diseases, right? So that's the challenge.